All right. Hi. What is your name and title, and what do you work on?
Yeah, thank you, Christine. First, thank you for this opportunity, and I truly have I've been enjoying working with your team, the biomedical engineering team. My name is Donnie Saw. I'm a pediatric ophthalmologist and strabismologist here at UCI. I'm a chief and professor in our department.
Great. And what disease conditions do you work with, or procedures do you perform?
It's very broad. As a pediatric ophthalmologist and strabismologist, the things that I take care of are congenital cataracts, glaucoma, ocular tumors, tear duct problems, strabismus, meaning misalignment of the eyes, any type of periocular tumors, um, and so it's pretty broad. So I can't like pinpoint any particular, um, a disease, but so I'm just going to say if I had to break it into two big categories, is like any type of ocular diseases that impact the pediatric patients, and any type of misalignment um, of the eye. If the eyes are misaligned, both in pediatrics and adult patients, we take care of those issues.
Great. I guess for the first category, with pediatric ophthalmology, what's historically been done to treat pediatrics in that field?
Um, yeah, so the one of the most common conditions that we take care of, and also it's one of the most common cause of blindness in pediatric patient, is patches. So we put a patch on the good eye to force the weaker eye to work harder. So that's kind of like what we have been doing for the last, I'm going to say, 300 years. And then now we are coming up with what we call dioptic treatment, where we stimulate both eyes using special glasses, and we show a movie with blurred image out of the one and clear image out of the other. And so we're stimulating both eyes at the same time. So that's called dioptic treatment. But there's some advancement in that area, tremendous advancement in that area. And then we treat them with glasses, or we treat them with the surgery. So if the cause of the lasia is because of the misalignment, then we go in, we straighten out the eyes by working on the muscles.
Oh, very cool. And that, I guess, brings to the second category you have, right, which is with misalignment, more in the adult population. What's been done to treat those conditions?
Can you repeat the question? I'm sorry.
What's been done to treat the conditions in the more adult patients
Oh, sure.
when you come in with misalignment?
Yeah. So the in terms of the obviously there's lots and lots of advancement and improvement in that area, but specifically related to the biomedical engineering. Unfortunately, a lot of the instruments that we're using today are the same instruments that we have been using for the last almost 90 years. So there hasn't been a lot of improvement in terms of the equipment and the surgical devices that we have been using. And I think there's a lot of areas that we can potentially improve on.
Is there any particular devices or pieces of equipment
Yeah. So
that you
one of
feel
the
are
areas,
outdated?
yeah. So one of the, I'm gonna say I'm gonna say like I could think of three areas that we could really improve on that I've been working on with the help of your some of your students. One is that it's the ergonomics. A lot of these tools are not really designed for, first of all, small hands. So people with small hands or big hands, it's ergonomically, it's very uncomfortable. I think there are ways that we can improve the ergonomics because when we are doing surgeries on these patients, it's not unusual for us to work on maybe 5 to 10 patients a day. So we're operating for 8 hours, almost nonstop. So a small, like a bad posture with your hand in this position, it may not be bad for 5-10 minutes, but if you're doing it for 8 hours, this is a recipe for carpal tunnel syndromes. And then also, so that's the ergonomics portion. And then the second portion is that the eyeball, a lot of the muscles that we work on are behind the eyeball. So it's very tough to reach that area. And unfortunately, these instruments are not really designed to reach a very tough locations. So there are small modifications that we can think about to make the instruments easier to isolate the muscles that are tough to that are tough or difficult for us to reach. So that's another area that I think we can improve on. And third is that after doing this for many, many years, you know how these muscles should feel. Like when you go in and you're operating, it's not something that people tell you this muscle is not normal and this muscle is abnormal. A lot of times that this is done through the mentorship and things like that. But I think we can. I think there are better ways to leverage the current technology that's available to us to help us with the teaching aspect. For example, if I am working on a muscle and this muscle is very, very tight, only way I can show this assistant is very, very tight is that for me to hand the instrument to the assistant, an assistant has to hold the instrument and pull on it, yank on it. And that's the only way I can teach that person, well, this is an abnormal muscle, and then this is a normal muscle. Well, instead of doing that, if we can have a instrument that can gauge and give you a something that's more objective, that's quantifiable, and giving you a scale, like this muscle is +1 tight, and this is +2 tight, and have some type of a grading scale, it's going to be a lot easier for us to teach the future generations.
Mm-hmm. Oh, that's great. And then in pediatrics, I know it's a lot of looking at vision and special, right, glasses and things. Do you foresee any improvements that can be made that can really help either speed up how they recover or how their eyes, I guess, retrain, right?
Yeah.
Or
Yeah.
ways to help them?
So, I first of all, the patches. So now what we're doing is that we have a computer chip that's built into the eye patch. So we can monitor the compliance on the patient. So in the past, we tell them you need to patch 2 hours, 3 hours, 4 hours, and they come back and then they didn't improve. So there's no way of me knowing whether the eyes didn't get better because of the poor compliance or because they have some other diseases. There's something else going on. Remember, we doctors are as good as the information that are fed to us that are accurate. So if we have inaccurate information, then we're going to come up with an inaccurate diagnosis and inaccurate treatments. So these type of computer chips can give us a better information and provide us with more accurate information that's reliable. So that's actually that's going on with the eye patches. In terms of the dioptic treatment with the computer programming, the industry is working on more interesting programs, and so that will get the pediatric population more engaged, and also, sorry, and then also trying to make the devices more comfortable to use, because these devices are great, but if they don't want to wear them, then it's worthless, right? And then in terms of the glasses, Christine, you have those nice glasses. Those glasses have been around for 200 to 300 years, and the styles have not changed. And it's the same. We tweak it, we modify it. But it's pretty much the same design. If you go back in time, 100 years ago or 200 years ago, the only difference is that only the wealthy can afford it. So if you had glasses and if you're watching an old English movie and if someone is wearing a glasses and you can automatically tell that person is wealthy. Well, unfortunately, in today's world, it's not too different. Glasses are expensive. I think we're trying to, with the help of your students, we're trying to create classes that are more economical and equitable, and that's comfortable to use. So that's something that we can work on. Obviously, in 2024, it is suspected that about 30 to 40% of the population in pediatric patients require glasses, but that number is expected to skyrocket. It just is skyrocket because we're spending so much time on near activities, using utilizing social media and small phone devices. So significant population of the people will need reflective corrections, and so this is going to be a bigger problem, because if you can't afford glasses, then you're not going to be able to see it. You're not going to be able to function well in school, and it's going to impact your school performance. It's going to impact your sports activities, and then it will impact. It can potentially impact your whole outlook of life.
And I'm sorry, my last question. I know you mentioned that that there's many people out there, right, that can't afford glasses, and that this isn't equitable, namely because of the economics. And I know you've seen this globally. Are there any considerations when trying to, for instance, making more affordable glasses and trying to give them to people in global settings? Has there been any barriers to be able to do that? And if so, what do you foresee to help us kind of alleviate those issues?
So the various industries are helping with this effort. I can't even, there are just too many to mention, but there are many great foundations that are available, that the general public can tap into. But still, there are some barriers of access. It's the access, because they have to be able to come to see us and get the proper prescriptions and proper measurements before they can get the glasses. So for example, Christine, just think about a child having to get a pair of glasses, and think about how many steps that's required. You have to go and you have to first have the transportation, get to a doctor, and then you have to have the complete exam, and you have to get a prescription, and then you have to go to an optician, and then you have to be fitted. And obviously, glasses is not one size fits all, so you have to be fitted. And then and then once you select the frame, the prescriptions that you brought from the eye doctor has to be put in. And so in order for that to happen, the optician has to send the prescription and the frame to the company or factory. They can cut the lenses and put into the frame, and has to be sent back to the optical. And then that patient now has to get the transportation to go back to the optical and be fitted. Because these frames, once you get them, they actually have to fit to your face. So the whole process right here is actually, there are a lot of steps that's involved. And I can tell you, you just mentioned the barriers. There are many barriers. I could talk about multiple barriers to get for a child to obtain a single pair of glasses. But I'm pretty sure you could imagine, we're talking the cost, cultural barrier, language barrier, transportation barriers. So these are some of the problems that one may face.
Great, thanks. And do you have any final words for our future biomedical engineers on things they should do and things they consider while they're innovating and developing new devices for your
Yeah,
field?
thank you. If I were not in a medicine, I would be, if I were not in medicine, I would be in biomedical engineering because I mean, I feel like that's that's where I spend most of my time right now, Christine. So, I just love I love the reason I love interacting with your students of the biomedical engineering. Um, I would say first they don't like they don't like status quo. I love the fact that I love the fact that they always question things and they're always looking for things to improve. I just I just want to tell the students that whenever people tell you this is the way that things are always done and it works for me, so don't rock the boat. Or if you hear things like that can be done because because it's difficult, it's just difficult. So I just hope that medical field traditionally is a very conservative field. There are many things that we do today that were done 50 years ago, 30 years ago, 100 years ago. And we resist changes. So, and here you are, you're innovators and trying to change. So you can see how there is a conflict. So I would like to challenge all of your students to keep that passion going, to keep that passion of wanting to change things for the better and improve the care that we provide for our patients and future generation. And don't give up, please. That's what I would want to tell them.
All right. Well, thank you so much, Dr. Seth.